Hello, I'm Nancy Carteron. I'm a rheumatologist based in Northern California, and I'd like to talk a little bit with you today about Sjogren's interstitial lung disease. So, was very happy to see that in the recent 2023 ACR chest guidelines that Sjogren's was also included in the guideline development. But I'm going to target a little bit on guidelines that Sjogren's pulmonologist and rheumatologist published in Chest in 2021. I think Sjogren's is probably not on the radar for rheumatologists, lung involvement as much as many of the other diseases are diseases like scleroderma or rheumatoid. But it's important to know that if you do screening in studies where they have done screening, high resolution CT scans, that up to 60% of people with definite Sjogren's have lung abnormalities that are visible on the scan. So I think it's under-recognized. So I think my main message today is for all those listening is really just to think about it. And even if you have Sjogren's alone or Sjogren's that's associated with another autoimmune disease, don't forget about the lungs. We know that with regards to the interstitial lung um, types of diseases, phenotypes in Sjogren's, that NSIP accounts for about 45%, and UIP 16%. Fairly unique, or at least a hallmark of Sjogren's being the lymphocyte. LIP we see about 15% of the time, and organizing pneumonia about 11% of the time. But with the lymphocyte, we certainly can also see bronchiolar involvement in follicular bronchiolitis, so there could be a spectrum. There's certainly a strong association, connection between Sjogren's and lymphoma, which occurs in the lung about 6% of the time, and amyloid as well, about 6% of the time. So there's a reason to consider a baseline pulmonary function test and maybe high-resolution CT scan in appropriate patients with Sjogren's. And depending on findings, certainly with nodules and monitoring patients with Sjogren's lung disease, there may be a role for PET scanning as well. One of the hallmark symptoms, which can be, underappreciated as something more serious in Sjogren's, may be a chronic cough, which can be reflective of interstitial findings or certainly in Sjogren's related to dry airways. So the spectrum of the underlying disease in Sjogren's, we think about in the lung as really going from inflammation to the fibrotic state. In the inflammatory state, the organizing pneumonia or the NSIP predominant. There's a subphenotype that our pulmonary colleagues talk about being fibrotic phenotype of NSIP, and then to the full-blown, more fibrotic UIP findings. But fairly unique to Sjogren's is the presence of more nodules, and particularly with cystic changes that we can see. And so the cystic formation, especially if there's a nodule that's very near the cyst, can be a clue, raising the index of suspicion for lymphoma in that area or amyloid. So important to know if those are there. The cysts can certainly become infected, which can be obviously problematic. And if they're large, they can be prone to rupture. So certainly for people who may have certain hobbies or even a vocation of scuba diving, you want to know about those cysts ahead. And so another important reason to know what the pulmonary status in your Sjogren's patients is earlier rather than later. So just think about it. I think about kind of understanding the activity, disease activity in the setting of Sjogren's, as well as then being able to pick appropriate treatments or the feeling comfortable in just monitoring patients with the basic immunology of them. Am I dealing with innate immunity? Or has it progressed down to the forward to adaptive, or is it cycling in that area? In Sjogren's, because the hallmark feature is really lymphocytic infiltration of target tissue, the B cell plays a very prominent role, progressing on to germinal centers, and then obviously increasing the risk of lymphoma. But in thinking of where your individual patient may fall along that spectrum. With regards to treatments, from the guidelines in CHEST from 2021, and not surprising, the first line treatment is glucocorticoids, but there are certainly a reason to very quickly add on a steroid-sparing agent, and the um, hierarchy really is considering mycophenolate and azathioprine, not surprising, but very early addition of them and titrating down the steroids as quickly as possible. For patients that have more severe disease, or if there's a really exacerbation and rapidly progressive, or if it looks like you may be dealing with progression onto a fibrotic phenotype, one needs to think about adding an antifibrotic, particularly nintedanib, and considering higher doses of steroids, pulsing with methylprednisolone, prednisolone, and adding rituximab, probably over Cytoxan early on, and in the um, CHEST recommendations from 2021, that was actually a strong recommendation. Don't forget about transplant evaluation, may not be on top of mind for Sjogren's patients, but assessing their disease severity and candidacy for transplant early is important, and there's no contraindication for them to be able to be transplant candidates. There are also, depending on individual situations in patients, think about calcineurin inhibitors, particularly tacrolimus as well. Since those guidelines were published in 2021, it's been heartening to see a number of Sjogren's centers globally have gone back and looked at their cohorts, and it's been borne out with regards to what the consensus statements were and what the rationale and supporting evidence was in that guideline. So I think that's so far has stood the test of experience. I think we're in an exciting time right now because with Sjogren's particular, we do not have any regulatory approved therapies, but we now have a number of late-stage development programs, and two very recently have announced that they've met their endpoint and are going for regulatory approval. One in particular that I'd like to mention for in the US is ianalumab, which is has a dual activity. So it's a monoclonal antibody directed against the BAFF receptor, but it ends up resulting in B cell death by ADCC, and it inhibits the BAFF cytokine production. And so along with, dovetailing on what we have had to use up to date, being rituximab. This is an exciting thing to stay tuned, and we'll be gaining a lot more information with regards to the specific treatments and how they work as we get newer treatments that come out. So thanks for listening. And just, as you see Sjogren's, whether it's occurring by itself or with one of our other autoimmune diseases, think about whether the person has lung involvement and consider whether it's appropriate to establish their baseline pulmonary activity with PFTs, plus or minus high resolution earlier rather than later. So thanks for joining.